Feeling stressed, overwhelmed? It's time to unstress your life and focus on controlling what you can control. I'm Dr. Ron Ehrlich, host of the Unstress Health podcast, inviting you to join the Unstress Health community and discover a holistic approach that helps you more effectively face the daily challenges of our modern world and effectively recover each and every day. Unstress Health is here to provide you with advice and support that is independent of industry and influence, an influence that's easy to miss but difficult to ignore. Our focus is on building mental fitness. Your mind can be your best friend or your worst enemy. Mental fitness is the key. Our three-phase approach targets mindset, boost your positive intelligence quotient, and move from self-sabotage to self-mastery. Secondly, the challenges. We redefine what stress means in our modern world. And thirdly, recovery. Master the 5 pillars of health. As a member of the Unstress Health community, you'll turn obstacles into opportunities with expert-led courses, curated podcasts, personalised health assessments, a supportive community, and much, much more. Join Unstress Health today, and together, let's not just survive, but thrive. Click on the link below or visit unstresshealth.com. Well, there are two stories that I am very interested in pursuing in a lot more detail. One is public health, which is what this whole program is about. But as I've moved into workplace wellbeing over these last couple of years, it's come to my attention that burnout is a problem. And burnout is characterized by the acronym DIE. People feel disengaged, that's the D. They feel ineffective, the I. And E is they are exhausted. And it is rather sobering to learn from our previous podcast with Dr. Tabitha Healy, an oncologist who now specialises in health coaching for the medical profession, when she shared with us rather disturbing statistics of 44% of doctors are burnt out and 60% of nurses. Now, when you juxtapose that against the epidemic of preventable chronic degenerative diseases, you start to get an idea of how these two stories may be connected. And what could be more disengaging and feeling ineffective than being in a practice which year after year after year, you have a waiting room full of people who really are coming in to have a prescription written, and they're going to be back in a couple of months for a repeat of those prescriptions. And it must be a little bit soul-destroying, particularly when you follow the so-called public health advice given to us by authorities, and you think, God, I'm doing everything I possibly can, and yet my patients is not making any difference, and all I'm doing is writing prescriptions. And that is a soul-destroying thing. Now, I have to say that I know many doctors who are practicing that kind of medicine. They call it allopathic medicine. It is perhaps more accurately referred to as prescription-based medicine, but the average appointment time is 10 to 15 minutes, maybe even less. They write a prescription. It's sobering to learn that 95% of antidepressants prescribed in this country, 1 in 6 Australians have antidepressants, are prescribed by general practitioners in a 10 to 15 minute appointment. So that gives you a hint as to the way allopathic medicine is practiced. And what I was going to say is I know many practitioners who do that, and I also know many integrative practitioners that really look at the root cause of disease and try to address that. And the thing both practitioners have in common is they truly want the best for their patients. So I want to say that right up front because it's a really important point. Both practitioners practicing very different forms of medicine want the very best for their patients. And if the evidence is anything to go by, there is a very serious problem with the way the vast majority of doctors are practicing medicine. I would say unwittingly, the medical profession of the last 40 years, and I say this unwittingly, they have presided over the worst epidemic in preventable chronic diseases in human history. However, there is an alternative for both doctors and patients. And it's a win-win-win all round, apart from the pharmaceutical industry, which is a loss. But that's another story. My guest today is Dr. Laureen Lawlor-Smith. Now, Laureen graduated from medicine in 1983, has spent almost 4 decades in general practice. Now, 2.5 years ago, she left mainstream general practice and now practices full-time, utilizing low carbohydrate and ketogenic nutrition to assist patients who can be helped by this approach. Now, there is a personal story here, and I don't want to spoil it for you, but it's a very compelling one. It's clearly not an uncommon one, and yet it's an incredibly inspiring one. And this is inspiring not just for patients, but if you are a health practitioner, a medical practitioner practicing allopathic medicine, or your doctor is, you should be pointing them to this episode because it can be a game changer. It has been a game changer. She co-wrote the guidelines for managing type 2 diabetes with therapeutic carbohydrate reduction, which were adopted by Diabetes Australia and the Australian Diabetes Society in 2023. I personally am very proud to have supported Defeat Diabetes in this endeavour as well. We'll be talking to Dr. Peter Bruckner, world-famous sports physician, and we have also spoken to Dr. James Mookie, former Australian of the Year in 2020, who has both have championed this cause, and Laureen has been at the coalface writing these things, and she tells a very compelling and inspiring story. I hope you enjoyed this conversation I had with Dr. Laureen Lawlor-Smith. Welcome to the show, Laureen.
Thank you very much for having me. I'm excited to be here.
Laureen, you've been in practice for quite a few years, and like many patients, a person's health is often a turning point in their personal and professional lives. And let's face it, doctors are human too. Did that happen to you?
Yes, completely. It happened to me, also happened to my husband, who's also a GP. So I graduated in 1983, and I've been in general practice for 38 years, owned my own general practice. And I'll do from a personal perspective, I've had problems with my weight all of my life, been on and off various diets, and I've followed the dietary guidelines, which is eat less, exercise more, focus on a low-fat diet. And essentially, I had lost weight and I'd put that back on again. I'd lose weight and put it back on again. And I just got fatter and fatter and fatter. And about 8 years ago, I was obese. I had pre-diabetes. I had fatty liver. I had sleep apnea. And I'd pretty much given up because I knew that eating less and exercising more doesn't work from my own experience and from patients' experience. And I just didn't really know where to go with it. I just felt trapped. And it was at that time that I came across low carbohydrate eating. And I went off to a low carb down under conference in Sydney. And I met the dietitian I work with now, Nicole Moore. And I started a low carbohydrate diet. And then I migrated over to a ketogenic diet. And I lost weight. My fatty liver went away. And my pre-diabetes went away. And my sleep apnea went away. And for the first time in my life, I felt like I had some sort of control over both my appetite and my eating. And subsequent to that, I started using low carbohydrate nutrition with my patients. And I discovered that diseases that I had previously told patients were irreversible and progressive, like type 2 diabetes, are in fact reversible. And a lot of the diseases that I was treating that I thought were long-term diseases like high blood pressure and fatty liver were also just manifestations of insulin resistance and were reversible too. So 2.5 years ago, I left general practice and I now work 3 days a week in low carbohydrate and ketogenic nutrition. And I do that is because that's people get better. So that's my little personal life. My husband Graham developed Parkinson's disease, early onset Parkinson's disease in his early 50s, about 12 years ago. And we became aware of the data around ketogenic diets and neurodegenerative disorders, including Parkinson's. And he's now on a strict ketogenic diet and he's doing fabulously well. So for someone who's had Parkinson's disease for 12 years, if you met him, you wouldn't pick it at all. He's on one medication and he's very, very, very stable. So it was honestly like experiencing a miracle, both personally but also professionally.
I mean, it's breathtaking. That story is breathtaking enough for one practitioner, but let alone collectively with over, I'm guessing, 60 years at least of clinical education and practice, and with a list of diseases that many people will be very familiar with, and be familiar with the advice they have received from their doctors. To hear this come, this is why I've been so looking forward to talking to you, Laureen, because I kind of suspected this was a story, but it's such an important story on so many different levels. I mean, presumably this wasn't just you going to university. You guys had both been through continuing education through that 30-year period.
Absolutely. And the problem is it's the way that I was treating diseases is still what's taught. Low carbohydrate diets have become a little bit more mainstream, but I would suggest the majority of practitioners still frown upon them and don't consider them to be, first line in terms of management. I mean, I had a patient with type 2 diabetes in this morning, and, type 2 diabetes is a disease of insulin resistance. It's a disease of carbohydrate intolerance. If you reduce your carbohydrates, you become more insulin sensitive and you can control your diabetes much better, if not reverse it. And she's having a fight with her endocrinologist, who's saying that she thinks she needs to eat more carbohydrates. So her process is increasing her carbohydrates and increasing her insulin dose, and increasing her carbohydrates and increasing her insulin dose. And meanwhile, she's putting on weight and getting sicker. So I think one of the most profound experiences was the sense of distress and guilt that I felt because, clearly for a considerable period of my practice, I've been doing patients harm by the advice I've been giving them. And yes, I've been following the guidelines, but I've been making them worse. And that's pretty sobering. It's more sobering to know that we continue to do the same thing. If you take a look at fatty liver disease, fatty liver disease is a disease of insulin resistance. It was not published about when I went through medicine. So I graduated in 1982, was not described until 1980. So fatty liver disease is a disease of insulin resistance. We tell people that they need to treat their fatty liver disease by decreasing their fat intake. It's got nothing to do with fat. It's all the excess glucose that can't be managed by the body because of the insulin resistance, just gets converted into fat and stored in the liver. So, we still say to people, decrease the amount of fat in your diet, and it doesn't work. Whereas drop your carbs and you can reverse it in 4 to 6 weeks in every single patient. The fatty liver disease is now 1 in 4 Australian adults has got fatty liver disease. An increasing number of Australian children have fatty liver disease. It's a leading cause of liver fibrosis and cirrhosis. It's a leading cause of liver cancer. It's the 4th most common cause of having to have a liver transplant in Australia. It's the number 1 cause in the United States. And this is a modern disease which has been brought on by our dietary advice, eating lots of ultra-processed foods, and we continue to manage it in completely the wrong way. Apologies, I went off at a bit of a tangent there.
No. This is actually a theme we've pursued on this podcast several times, and it's always great to hear it firsthand from not only in the trenches, but somebody who's been suffering from all the diseases that they've been treating. And I know that type 2 diabetes used to be called late onset diabetes, but I think that's true of children now too.
Absolutely. It's an increasingly an issue in children. So the incidence of type 2 diabetes has doubled since I've been in practice. So it's about 13% of Indigenous Australian adults have got type 2 diabetes. It's 1 in 20 Australian adults. Pregnant women, it's 1 in 6 pregnant women get gestational diabetes. And if you're an Indigenous Australian, it's 1 in 4. Like, this is this terrible epidemic which has been created by the advice we're giving people. And we get what do we do? We don't change the advice. We just prescribe more medication.
I mean, whenever people think of nutritional stress, and it's a word that we've used on this program, and I've used in my practice for many, many years, People always think of fast food and pizzas and all that, but I've always considered the greatest nutritional stress to have been the food pyramid, which morphed into the food plate, which now morphs into the Australian Healthy Eating Guidelines. That is the greatest nutritional stress on society. How did we get it so wrong?
I think if you look, I think we based our dietary pyramid, our guidelines on what happened in the United States. And my understanding was that was about politics and industry. So there's two things that the food pyramid's got wrong. Number one, the bottom of the food pyramid is carbohydrates. And we're told we should have several serves of carbohydrates a day. But the second thing we were told is that we should stop eating animal fats, saturated fats, and we should replace them with seed oils, polyunsaturated seed oils. And I think those two things together have both been problematic. So, we're eating lots and lots of carbohydrates, but people are focusing on low-fat food, which tends to be higher in sugar, but also people are eating processed fats, which were actually only invented at the turn of last century, which are associated with a higher incidence of inflammation, but also a higher incidence of insulin resistance. So the food pyramid is just completely wrong. And, my concern, they're rewriting the dietary guidelines again. My concern is that a lot of the people writing the dietary guidelines have conflicts of interest. And as harsh as this may seem, I think if you're writing the dietary guidelines, you should be receiving no money from the food industry, and you should be receiving no money from the pharmaceutical industry. Otherwise, you're conflicted. But that's not the way things run. People who do have conflicts of interest do get put in these positions, and yes, they declare them. But I think it's an amazing person who can have such a conflict of interest and not let it affect the way they make decisions.
Or affect their livelihoods. But I guess there's another aspect to this, which is not just the guidelines, but it's actually seeing the results at the coalface as the patient sits opposite you. And I know we had a conversation before we did this interview. You've got involved in sitting down round table. You're based in South Australia. And as you've already alluded to, endocrinologists, after a patient has seen a GP, they're often referred to the specialist to manage their diabetes, and that's often an endocrinologist. And you've had some interactions with the specialty. How was this incredible results that you had got yourself and were observing in your patients? How exciting, how thrilling to be reversing disease. What could be better as a doctor? How was that received?
I think the endocrinologists are looking for the large double-blind, well, no, it can't be double-blind, but the large randomised trial comparing people on a low-carbohydrate diet with people not on a low-carbohydrate diet. And in the absence of that, they're pretty sceptical. The problem you've got is that people choose what they're going to eat. I can say to people, well, I think you should decrease your carbs, but if you don't want to do it, you're not going to do it. So if you have a look at, there's a guy called Dr. David Unwin, who is a GP in the United Kingdom, and he, I think, has got the longest term data of anywhere in the world, published data of anywhere in the world. And basically for the last 10 years, every type 2 diabetic in his practice has been offered the opportunity of trialling a low carbohydrate diet, and less than 50% of them chose that. And I think that's probably what it's like in the real world. There are people who'd rather take the tablets and change their diet. But, of that 50%, half of them achieved type 2 diabetes remission at 10 years. So that's 50% type 2 diabetes remission at 10 years. Or overall, I think it's 23% over the whole group, including the group that didn't undertake low carbohydrate diets. Yeah, that's incredibly powerful. If I had a drug that gave you, for the whole population, 23% type 2 diabetes remission at 10 years, I would be a very rich person and I'd probably have a Nobel Prize. But because this is a dietary change, he hasn't won any awards. But the problem with that sort of information is it's not good enough for the endocrinologists. They really want the randomised controlled trial.
So yes, you have. You still got me here. I'm just dumbstruck. That's why you may have thought that the thing froze, because I'm just kind of almost with my mouth open, amazed that even a patient sitting in front of you who you've tried this on and comes back and all the stats stack up, you are seeing a remission before your very eyes. But that's not enough.
No, it's not enough. So the endocrinologists I would say mostly still skeptical. I mean, I was privileged enough to be able to get together with Professor Steve Strakes here in South Australia, who's an endocrinologist, and together we put together a set of guidelines for using therapeutic carbohydrate reduction in type 2 diabetes, which have been adopted by Diabetes Australia and the Australian Diabetes Society. So I think that's given it a little bit more legitimacy. And in particular, the endocrinologists are concerned about what the potential downsides of these dietary changes are. And so we covered off on all of those concerns as well. So it is becoming more mainstream, but I'd consider it to be largely fringe. You know, I would suggest, I don't know, probably 95% of GPs probably aren't on board with it. And I'd say the absolute majority of endocrinologists. So if, for example, in South Australia, we have one endocrinologist who practices low carbohydrate medicine, and the others would use the standard Australian dietary guidelines.
Hi, Dr. Ron here, and I want to invite you to join our Unstress Health community. Now, like this podcast, it's independent of industry and focuses on taking a holistic approach to human health and to the health of the planet. The two are inseparable. There are so many resources available with membership, including regular live Q&As on specific topics with special guests, including many with our amazing Unstress Health Advisory Panel. Now, we've done hundreds of podcasts, all worth listening to, with some amazing experts on a wide range of topics. Many are world leaders. But with membership, we have our Unstress Lab podcast series, where we take the best of several guests and carefully curate specific topics for episodes which are jam-packed full of valuable insights. So join the Unstress Health community. If you're watching this on our YouTube channel, click on the link below or just visit unstresshealth.com to see what's on offer and join now. I look forward to connecting with you. I mean, apart from a reduction in revenue for the pharmaceutical industry, what are the other adverse reaction? What are the other, negative side effects of a low carb diet? I mean, I know there'd be less medication on many different fronts, and that could have a certain impact on revenue. And I can understand that would be a very negative thing. But what are some of the other negative side effects of a low carb diet?
I'll just pick up on you and just say, so David Unwin saves $130,000 Australian a year in his small general practice on diabetes medication in his patient group. So it does save a lot on medication.
Yes.
The problems with low carbohydrate diets only come if you're on medication. So if you're on a medication, so low carbohydrate diets are going to decrease blood sugar. If you're on a medication that's also going to decrease blood sugar, there's a risk your blood sugar might drop too low and you might have a hypoglycemic episode. So drugs which decrease blood sugar, which include a group of drugs called sulfonylureas and insulin, need to be adjusted downwards. And that's pretty simple and straightforward. The second group of drugs is drugs which reduce your blood pressure. So you go on a low carbohydrate diet, in general, your blood pressure will drop. And this means that a lot of people don't need their blood pressure medication anymore. And if the patient isn't aware of that and we say, okay, let's drop your carbs down and don't talk to them about their blood pressure, then they may in fact become lightheaded and fall over and come to harm. So again, with all our patients, we warn them. For most of them, I get them to measure their blood pressure at home, and I give them a deprescribing regime. So as their blood pressure drops, they can decrease their blood pressure medication. The third group of drugs is there's a group of drugs which increase ketone production. So low carbohydrate diets, ketogenic diets increase ketone production. In general, a low carbohydrate or ketogenic diet will not give ketoacidosis. So ketoacidosis is a disease where ketones are high and the blood is acidotic, and it's a severe illness, potentially fatal. It usually occurs in type 1 diabetics who aren't on enough insulin. It generally doesn't occur in people, type 2 diabetics who are on a low carbohydrate diet. except for when you add in a drug which also increases ketone production. So there's a group of drugs called SGLT2 inhibitors, which work by causing the leakage of glucose through the kidneys. So you lose about 20 grams of glucose through the kidneys a day with these drugs. They also increase ketone production. And these drugs by themselves in patients with type 2 diabetes can produce ketoacidosis. So that was very long-winded, but if we start with a diet that can increase ketones and we add in a drug which can increase ketones, the combination increases the risk of ketoacidosis. Right. And again, this is managed by, there's a couple of ways you can do it. We used to just stop the SGLT2 inhibitor, and it's about a diabetic control largely, and just monitor them. Endocrinologists weren't happy with that approach, mainly because these drugs also are quite useful for renal failure and heart failure. Now what we do is we maintain the patient on them, and we talk to them about sick day management plan, and if they're sick, they need to stop them, and basically make them acutely aware of the fact that this may be an issue, and usually I get them to check ketones as well. So just in summary, drugs that drop blood sugar, that drop blood pressure, or increase ketone production all need to be managed in people who are on low-carb diets, and that's really simple and straightforward to do. And apart from that, apart from some really rare inborn errors of metabolism, low-carb ketogenic diets are very safe things to do.
And you've mentioned ketoacidosis a couple of times there, and I think I have a sense that many doctors don't fully appreciate the difference between ketoacidosis and ketosis. Is that your observation?
Completely. So
just give us ketoacidosis and ketosis 101 definition. What's the difference in case a doctor is listening to this and just needs a little bit of a refresher?
So ketoacidosis is when you produce excessive quantities of ketones and you have an acid-base imbalance in your blood, so your blood becomes quite acidotic. That's dangerous, potentially fatal. Ketosis is a normal physiological state. So when you are burning fat for fuel, one of the byproducts of burning fat for fuel are ketones. And in fact, being in ketosis is our natural state. So newborn babies are in ketosis, breastfed babies are in ketosis. Throughout our 2 million years of being hunter-gatherers prior to the agricultural revolution, we were all in ketosis all of the time. So it's a natural state. It's not associated with an acid-base balance. In fact, you can have incredibly high ketone levels and not be acidotic and be completely fine. Now, I'll give you an example. For example, we treat people with neurodegenerative disorders. We also treat people with a sort of brain tumour called glioblastoma, which is a almost universally fatal brain tumour. In these people, we need to get really high ketone levels. And we get people with ketone levels of 4, 5, and 6. They don't have excessive acid production. They are completely healthy. They feel completely fine. It's all to do with that acid-base imbalance. So you can't diagnose ketoacidosis just on ketones. You need to actually look at acid-base balance as well. And the difference is if you're in ketosis, you feel really well, your brain's functioning well, you feel great. Whereas if you're in ketoacidosis, in general, you're vomiting and feel really unwell. So most people don't understand the difference. And most people would say, if your ketones are over, let's say 1.5, oh my God, this is a huge problem. But for our patient group, it is absolutely not a problem. In fact, it's a therapeutic target because we want them to produce lots of ketones because it's the ketones that have a therapeutic effect on their brains.
It's interesting, isn't it? Because it's well known and it's the basis of PET scans that cancer cells love glucose. So I think they inject radioactive glucose, and the radioactive glucose will rush to the cancer because cancer loves glucose. So it just kind of seems almost too simple to suggest you shouldn't be feeding a cancer cell.
It's interesting. I mean, it's ketogenic diets have got evidence in various forms of cancers, but not all cancers. And again, the problem we've got is the funding for these studies comes from the pharmaceutical industry, and there's no money to be made by advising people about ketogenic diets when they've got cancer. So there's just a paucity of research. There is increasing research, but there is a paucity of research. So there's a gentleman in New Zealand, and Hamilton, New Zealand, by the name of Dr. Matt Phillips. Don't know whether you've ever heard of him. He's a neurologist. You should have a chat to him. He's just an amazing amazing man, and he's one of the people in the world who's doing a lot of research on ketogenic diets. So he's got evidence in Parkinson's disease, Alzheimer's disease, Huntington's chorea, motor neurone disease, and Alzheimer's disease. And he's in the middle of a big study treating people with glioblastomas.
Wow. I mean,
again,
sorry,
I was going to say glioblastoma is a death sentence. It's a death sentence. And, again, I have one patient we're treating at the moment, and he's down the track. He should have had a recurrence. He doesn't have a recurrence yet. I can't tell you what's going to happen in the future, but this gives people a lifeline. It's just an amazing, I come to work. I love coming to work because I really feel like I'm helping people. I'm offering people treatment that might not be available elsewhere. But a lot of the time I just see people get better. They feel better. They lose weight if they want to lose weight. Their labs all get better, and they're empowered because they have now got a tool that they can use to help them stay healthy.
Now you've just said something that has piqued my interest, particularly as a practitioner of 38 years, many years practice. You love coming to work, and we did a program recently with one of your contemporaries down in Adelaide, Dr. Tabitha Healy, who has been talking about burnout in the medical profession, and the statistic of something like 44% of medical practitioners and 60% of nurses are suffering from burnout, characterized by the acronym DIE, disengaged, ineffective, and exhausted. And here you are, after 38 years, anything but burnt out. Well, why?
So 7 years ago, I was burnt out. I really didn't know how much longer I could do it for. One of the beautiful things about general practice, long-term general practice in the same area, is you develop long-term relationships with people. You see people over decades. You know their parents, you know their kids, you know their grandkids. You know what their strengths are, you know what their challenges are. And, you develop a deep investment in their well-being. And quite frankly, watching people get sicker and sicker in spite of what you're trying to do and being on more and more medications is just soul destroying. It's really difficult. Yeah, I was burnt out. I think if you look at there's a lot of reasons why general practice is dying. But general practice is, because of the epidemic of chronic illness that we've got, it's just become a really difficult place. And there's this, sometimes this sense of no matter what you do, things don't get much better. So we're now down to 11% of graduates are choosing general practice. We need 50% of graduates to choose general practice just to replace the ones that are leaving. And you probably, everybody knows it's really hard to get a GP appointment. Yeah, and I think it's because, a lot of people just don't get better, and that's very difficult to take.
And a lot of people don't get better following the advice of the doctors like you were giving for so long. I mean, that in itself must be soul destroying. I remember we did a program with Julia Ruckledge, professor of psychology in New Zealand, on food for the brain kind of thing. And she said it's perfectly natural for doctors to be skeptical and curious and skeptical. And my question to her was, at which point of the medical education process does that curiosity kick in? Is it only in second or third year when you're studying pathology and pharmacology, or does it kick in first year when you're studying biochemistry and physiology? Because you've made the point about double randomized controlled trials, but we still do have the basic sciences, don't we? Do they still count for something?
I guess they are, but I think, when you're a medical student, you take everything, well, I did, you take everything as gospel. And I often say, I came out of medical school and I was idealistic, and I thought I'd been given all the information and all the knowledge and the skills I needed to change the world, and it's not true. I think to some extent, unless you have a personal experience of ill health and the system failing you, I think it's very difficult to make the leap, because it is difficult making the leap from what I've been doing is harming people to this is something else I can do. So I think, the people who are naturally slender and metabolically healthy, don't have too many problems, and they see all these patients coming in, putting on weight and getting diabetes, I think it's much easier to blame that on the person rather than to actually sit back and saying, okay, we've got, the incidence of obesity, for example, has quadrupled since I've been a general practitioner. It's quadrupled. Like, it's unbelievable. We now have 1 in 2 Australians have got a chronic illness. 1 in 3 Australians have got 2 or more chronic illnesses. We're spending 90% of the money that we're spending on health on chronic illnesses. It's only if you really experience that yourself that I think you can look and say, okay, is what we're saying wrong? And is there another way? And I think what fascinates me about the whole thing is, everybody is sitting back looking at this absolute disaster that is our healthcare system. It's just, being crushed under the deluge of chronic illness, and nobody's sitting back and saying, what's causing all of this? This is really strange. Why have all these illnesses dramatically increased over the last 4 decades? It's not that the population's getting that much older. We've all not suddenly become lazy and gluttonous. Our environment has changed, and it's time to look at the environment and tackle the environment, tackling our food environment and the rest of our environment, see if we can stop this from happening.
Yes, I always wonder when I hear people argue that it's because we're getting older as a population. It doesn't quite explain why children are now getting sicker as well, because they're not getting older. They're still children. Children do get older. But listen, when we talk about low carb, this is another thing too, isn't it? That what is low carb to one person, if, for example, the dietary guidelines recommend 310 grams of carbohydrate a day, and then they do a study on low carb, in inverted commas, and it's 200 grams of carbohydrate a day, and they say it doesn't make much difference. And to other people, low carb means something else. What does low carb mean to you?
So the official definition is less than 130 grams of carbohydrates per day. In the sort of people we are seeing who they're overweight, or they have metabolic problems, or they have some sort of health problem, it would be unusual to get someone to respond to less than 130 grams a day. In general, we would start at less than 70 grams a day. For people who are really unwell, for example, who have type 2 diabetes, we'll often start them at the ketogenic range, which is less than 20 grams of carbs per day. But the reality is everybody's got a carb threshold. Everybody's got a level at which their system is going to stop coping with carbs, and that depends upon your age, your genetics, and what sort of damage you've done to your system before. So our attitude is we tend to start pretty low, and then when people achieve what they want to achieve, we gradually increase their carbohydrates until they hit the point where they know the wheels are going to fall off. And in general, the person knows that themselves, because when you've got insulin resistance, you're hungry all the time, you crave carbohydrates, you're really tired, you can't lose weight, and you've got brain fog. And what tends to happen is that that all goes away. As you increase your carbohydrates, all of a sudden your hunger kicks up and you're feeling tired and you've got the brain fog back again, so you need to back off again. So that was a long-winded, but
No, it's good.
The minority of people, you have to be a really fit, active young person to be able to cope with over 300 grams of carbs a day. It's just not physiologic. So yeah, it has to be less than 130. That's the definition. But in general, you need to go significantly lower than that.
And given that 1 in 2 Australians are suffering from a chronic illness, the management of the medications through this process is clearly a very important part of the patient management story, isn't it?
Completely. I spend the majority of my time deprescribing, which is a joy.
Yes.
It is it's an unusual thing for me to prescribe something new. In general, I'm spending my time deprescribing. And patients, they just love it. And sometimes it's heartbreaking. Sometimes people come in on this huge list of medications, and you really wonder how many of them are actually doing them any good, and how many of them are doing them some harm.
And how many of them have side effects which need to be managed by another medication? I mean, I've said it often, our healthcare system is a fantastic economic model. It's just not a very good health model.
I agree entirely.
Yeah.
Absolutely entirely.
Yeah. You both, you mentioned your husband, who's a GP, was diagnosed with Parkinson's 12 years ago, and on a ketogenic diet, you wouldn't even know he's got Parkinson's. He's managing it well. You listed out your liver, OSA, obstructive sleep apnea, diabetes, etc., etc. You guys are on a ketogenic diet, I'm assuming.
Yep, that's right, a
Yep.
ketogenic diet.
What does a day in your household look like?
So in general, we are both on time-restricted eating. Principally, I mean, A, because I think it's helpful for your metabolism, but B, when you drop carbs, most people aren't hungry in the morning. And I'm a big advocate, if you're hungry, eat, and if you're not hungry, don't. So I would have a black coffee for breakfast. Graham would have a coffee with some cream. And again, he's got a higher metabolic rate than me. He's also more active than me. He's a crazy cyclist. So he'll have a coffee with some cream. He might have some MCT oil to kick up his ketones.
Just remind our listener what MC.
So medium chain triglyceride oil, you can just buy coconut oil. Every supermarket's got medium chain triglyceride oil in it. It's an outside source of ketones, so it kicks up your ketones without your liver having to produce ketones. And then for both lunch and dinner, we'll have a piece of protein, which is usually animal protein, 99 times out of 100, chicken, meat, fish. And then we might have some vegetables. So it would be a salad or some vegetables, some cooked vegetables, which are usually above ground vegetables. We might have, for snacks, we might have nuts. I quite like beef jerky, barbell beef jerky. I'll give them a plug. They're grass-fed, organic, tastes fantastic, no additives. So I have some beef jerky. We might have some cheese. For a treat, we might have some berries and some cream. That's pretty much it. Now, it sounds pretty boring, but it's great food. And we do things like for the lunch day I had cottage pie, which is essentially a beef mince base with some cauliflower mash on top. Tastes great. You can do all sorts of different recipes. It's pretty much a yummy diet.
Laureen, if you were meeting Dr. Laureen just as she's about to graduate, what would you be advising her professionally?
I would be talking to her about carbohydrates. I'd be talking to her about the dietary guidelines came in just as I graduated. So I graduated in 83, they'd just come in. I'd be talking to her about the dietary guidelines and asking her to have a look at the science, which would have been very difficult then because there's lots and lots of information about carbohydrates and saturated fats, particularly saturated fats being okay in the diet now. I don't know that there was that much in the literature then, but I just talked to her about taking the dietary guidelines with a pinch of salt and maybe not taking the other guidelines at face value, maybe just having a think about whether they made sense or not.
Laureen, thank you so much for joining us today. For sharing the story, which is inspiring, and I'm so glad to hear you're still in practice and enjoying it so much.
Okay, thanks very much. I've really enjoyed the chat.
Well, what a unique idea. Addressing the cause of disease and in the process ticking so many boxes of accompanying diseases and side effects that you end up with a patient who is healthy. I mean, how exciting is this? How inspiring is this? And how rewarding is this? Here was Laureen who was really facing burnout herself, experiencing very poor health with all the conditions she outlined in this episode, and not only turned it around for her own health. There's a win. Not only now finds medicine inspiring and enjoyable after almost 40 years in practice, there's a win, but inspiring patients or guiding patients to better health, there's a win, and the overall effect on public health is a huge win. In fact, the only loser there is the pharmaceutical industry, and it may go a long way to explain why it is the big industry at US $1.6 trillion a year and growing by the day. This is a great story, and it's nice to know that Diabetes Australia and the Australian Diabetes society are embracing this low-carb approach. And interesting also to hear of Laureen's husband, who is also a GP, who has been diagnosed 12 years ago with Parkinson's and on a ketogenic diet, which is a very powerful tool, particularly with neurological problems, but many others, you would barely notice that he has Parkinson's. Such an inspiring story. It was so great to speak to her. I hope this finds you well. Until next time, this is Dr. Ron Ehrlich. Be well. Feeling stressed, overwhelmed? It's time to unstress your life. Join the Unstress Health community and transform stress into strength. Build mental fitness, from self-sabotage to self-mastery. And together, let's not just survive, but thrive. Expert-led courses, curated podcasts, like-minded community and support, and much more. Visit unstresshealth.com today. This podcast provides general information and discussion about medicine, health, and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast express their own opinions, experiences, and conclusions.